So, think about that for a second. What if a simple fever was the first thread you could pull to unravel a life-threatening mystery buried deep inside the heart? This is the exact question that doctors face when they're trying to solve the puzzle of infective endocarditis. It's a race against time where every little symptom counts. So let's start our investigation. Every investigation has to start with understanding the crime itself. And in this case, we're not talking about a simple break-in. No, this is a full-blown siege on the heart.
So what exactly is infective endocarditis, or IE for short? Well, it's an infection of the endocardium. That's the super smooth, delicate inner lining of the heart's chambers and, crucially, its valves. You can think of it like the smooth inner wall of a fortress, a wall that's about to come under a serious attack.
So how does this siege even get started? Well, it happens in stages. First, something has to injure that smooth inner lining of the heart. This creates a rough spot, which allows platelets and fibrin to basically form a little nest, a perfect foothold on that castle wall. Then, bacteria that are just traveling through the bloodstream find this perfect little spot and they set up a colony. These colonies are called vegetations. And these things are so dangerous. They're not just sitting there. Bits and pieces can break off, shoot through the bloodstream like tiny missiles, and cause all sorts of damage somewhere else in the body, like the brain or the lungs.
Okay, so any good detective knows you have to understand the victim to understand the crime. Who is most vulnerable to this internal siege? Let's take a look at the most likely targets. You can really break down the potential targets into two main groups. On the one hand, you have your high-risk folks. We're talking about anyone who's already had EIE before, people with prosthetic heart valves, or those with certain heart conditions they were born with. Then you've got the intermediate risk group. This includes people with conditions like rheumatic heart disease, or even those with implanted devices like pacemakers. You see the common thread here, right? It's all about having some pre-existing condition that makes that inner lining of the heart just a little more vulnerable to that first bit of damage.
So how does the invader, the bacteria, even get into the bloodstream to begin with? Well, there are actually a bunch of ways. It could get in directly through a needle, say from IV drug use. It can happen during an invasive medical procedure, or even from a seemingly totally unrelated infection somewhere else, like on your skin or in your mouth. This is exactly why a doctor might ask if you've had any recent dental work. It can be a huge clue.
All right, the stage is set. The investigation officially kicks off when a patient shows up with symptoms. But this is where the mystery really starts to deepen.
See, the initial symptoms are almost never a big flashing sign that says heart problem. It's usually something vague, like a fever that just won't go away, or general signs of a really bad infection. It can even look like other diseases entirely, sending the investigators down a completely wrong path.
And the first round of lab work, well, that often just adds to the confusion. Tests for inflammation might be sky high, but all that really confirms is that something is wrong, not what is wrong. They just aren't specific enough to point the finger directly at IE. And that brings us to the absolute game changer. The first piece of hard evidence, the real smoking gun, comes from blood cultures. To solve this case, you have to catch the bacteria red-handed, right in the bloodstream. It's why doctors will take multiple blood samples over a period of time to give them the best possible chance of catching the culprit.
Okay, so once you've identified the culprit, you need to see the crime scene. And this is where imaging comes in. An echocardiogram, which is basically an ultrasound of the heart, gives you the crime scene photos. It lets doctors look directly inside and see those vegetations or any other damage right there on the heart valves.
So now we have our evidence. We have the blood cultures, our culprit, and we have the imaging, our crime scene photos. But how do we put it all together to secure a conviction, or in this case, a definitive diagnosis?
Well, this isn't just guesswork. Clinicians use a really formal system called the Duke criteria to weigh all the evidence. Think of it as the official rulebook for this investigation, a way to systematically identify specific major and minor clues. So the first major clue is pretty straightforward. It's the equivalent of catching the suspect at the scene of the crime. It's all about proving that the invading bacteria is there and it's active.
Now, to meet this major criterion, it's not enough to just find any positive blood culture. The rules are specific. You need to find typical IE-causing bacteria, like strep or staph, in at least 2 separate samples. Or you need proof of a persistent infection, with cultures that are still growing bacteria more than 12 hours apart.
The second major clue is all about visual confirmation. It's not enough to know the culprit is in the bloodstream. You have to physically see the damage it's causing inside the heart.
And this shows you exactly what doctors are looking for on those scans. They're searching for definitive signs, a vegetation growing on a heart valve, an abscess, or maybe a problem with the prosthetic valve, like a dehiscence, which is where the artificial valve actually starts to pull away. Seeing any one of these is a huge piece of the puzzle.
But what if you don't have two of those slam-dunk major clues? Well, that's where the minor or circumstantial evidence comes in. These are all the little details that help build a really compelling case when the major evidence isn't quite enough on its own.
So these minor clues include things we've already talked about. Having a risk factor like a heart condition, that persistent fever, or blood cultures that are positive but don't quite meet the strict major criteria. It also includes vascular phenomena. That's when those little clots break off and travel, and even specific signs from the immune system, like tiny, tender spots on the fingers or toes called Osler's nodes.
Okay, with all the evidence gathered, both major and minor, it is finally time to deliver the final verdict and officially close this case.
And this table shows you exactly how it's done. It's like a formula. You can get a diagnosis of definite IE in a few different ways. 2 major criteria, boom, you're there. Or 1 major plus 3 minor clues. Or even with just 5 minor clues. This systematic approach is what gives doctors the confidence to make the call. It's that aha moment where all the scattered pieces finally click into place.
And of course, once the diagnosis is confirmed, the story is far from over for the patient. The focus immediately pivots to treatment. This means long courses of powerful, targeted antibiotics to kill the infection, and in some serious cases, it might even mean surgery to repair or totally replace those damaged heart valves. The mystery is solved, and now the recovery can begin.
Infective endocarditis is just such a powerful reminder that sometimes the smallest, most misleading clue can be the key to diagnosing a truly life-threatening condition. It just goes to show you that inside the incredible complexities of the human body, there are always more mysteries just waiting to be solved. So, what will we uncover next?